Thank you, respected chairpersons. And thank you, Dr. Manoj, Dr. Purvi, and Dr. Bansi for inviting me here. When we talk about type 2 diabetes in the Indian population, it is always about the insulin resistance because that's the main pathophysiology which we see and come across most of our thin, lean Indian patients. So these are my disclosures. So as the pandemic of diabetes is increasing, so is the burden, and so we need to pinpoint and treat to target what the patient demands. So it is the phenotype, what we look into, the diabetic phenotype, it is mostly the insulin resistance. Insulin resistance in Indian population came up as a theory. When Dr. Yagnik published this data, Dr. Yagnik has a very interesting data about the thrifty gene concept. What is thrifty genes? When a mother who is poorly nourished during a pregnancy will tend to have a baby who is underweight, and that baby once grows into an adult and is exposed to all the high calorie and the refined food, this kind of adults, this kind of babies who are born underweight to an undernourished mother may develop type 2 diabetes mostly because of insulin resistance, because these babies are known to have fatty pancreas. More fat in the pancreas itself is resistant to the effect of glucose or insulin, and thereby there is decreased sensitivity of this pancreas to secrete insulin as a response to glucose. So this is how the insulin resistance in India, or rather the Indian phenotype, has developed. So looking into it in more in depth, Dr. V. Mohan has a very good study on this. That's the inspired study, which wherein almost 19,000 individuals with type 2 diabetes across 9 states of South India with a duration of less than 5 years who had their first clinical visits were differentiated or identified as clusters of different types of diabetes. What was seen? 35.8% type 2 had mild age-related diabetes. 26.2% type 2 diabetes had severe insulin deficient diabetes. 25.9% had insulin resistant obese diabetes, and 12.1% had both combined insulin resistant and deficient diabetes. So which makes almost 38% Indian type 2 diabetic having insulin resistance as the underlying pathophysiology. So coexisting insulin deficiency and resistance makes these people more prone to micro as well as macrovascular complications. Specifically, what was seen in patients with insulin resistance and deficient diabetes was they developing retinopathy and other microvascular complications. So because of insulin resistance, all these pathologies, atherosclerosis contributing to ISD, stroke, PVDs, low HDL, increase in the thrombosis, inflammation in the liver leading to cirrhosis, excessive TG, high BP, hyperglycemia, visceral obesity, certain microvascular neuropathic changes, urinary frequency, headache, bloating, apnea, cardiomyopathy. So when a person is having insulin resistance, the risk of cardiovascular disease doubles, and 80% of these patients will die because of CVD. And this specifically is because of the pro-atherogenic effect of insulin. Insulin resistance will ultimately lead to hyperinsulinemia. So this itself will, which is pro-atherogenic, and thereby lead to the cardiovascular events. Similarly, like peripheral insulin resistance, there is also the liver insulin resistance, which is the main reason for developing MASLD. My previous speakers were talking extensively on MASLD. insulin resistance itself is a pathogenesis as well as it is a contributing factor to the progression from steatosis, steatohepatitis, cirrhosis, and maybe to hepatocellular carcinoma. So it is all the inflammation going on because of the insulin resistance in the liver causing the sequelae of MSLD. So signs and symptoms we see commonly is the abdominal obesity. Abdominal obesity is mostly because of the visceral fat, and it is associated with increased levels of insulin resistance in the skeletal muscles and the adipose tissue. Acanthosis nigricans, very classical. These are the velvety patches which are present on the flexor folds of our skin. It is classically seen in insulin resistance, can affect any age, men or women, and this pigmentation is because of hyperkeratosis. It is not because of increase in the melanin, it is hyperkeratosis in the skin. Then acrochondrons. These are also very commonly seen on the, also called as skin tags, fibromas, fibroepithelial polyps, mostly seen on the neck, on the, around the orbits, axillas, so associated with insulin resistance. So what investigations we do to identify insulin resistance? A lot of tests, very few which are clinically relevant. So the various tests of them are the fasting blood glucose and fasting insulin levels, from which we calculate the HOMA-IR value, then OGTT, HbA1c, then lipid profile, which will show a classical diabetic dyslipidemia, that is high TG, low HDL. The advanced markers are adiponectin, leptin levels, and free fatty acids. Now the gold standard here is hyperinsulinemic euglycemic clamp, which is more of a research kind of a test, not done in the clinical setting, and frequent sampling of intravenous glucose tolerance test. So the clinical indications are always the guiding path to how to identify a person walking into a clinic as whether having insulin resistance. So the waist hip ratio, central obesity, classical, presence of acanthosis nigricans, very classical, and features of other metabolic syndromes like high BP, dyslipidemia, impaired glucose tolerance. So in practice, we use HOMA-IR, OGTT, HbA1c, and lipid profile, and the physical characteristic where we can identify the person is having insulin resistance or no. So drugs which deal with insulin resistance, the most important two, metformin, it reduces hepatic glucose output, increase peripheral uptake of glucose, first line, and the most specific, which we'll be talking more in depth, is the TZDs like pioglitazone. So it is a PPAR alpha gamma agonist, increases insulin sensitivity in the fat and the muscles, both in the peripheries as well as in the liver. Risk factors we all know. Then other drugs are the incretin based drugs, GLP-1 receptor analogs, dual GLP-1 GIP receptor agonists like tirzepatide, SGLT2 inhibitors, DPP4 inhibitors, and and other agents like statins, ACE inhibitors, ARBs. They improve the metabolic profile. Anti-obesity drugs, orlistat, semaglutide, even tirzepatide, when used as anti-obesity drugs, reduce insulin resistance. Of course, the main and the most effective is lifestyle along with the drugs, which has the best outcome. So talking about pioglitazone in depth, it is the only anti-diabetic drug that functions predominantly as an insulin sensitizer in the peripheries as well as in the liver. So though it may be the second or the third line in the as per the algorithm, but when a patient is predominantly demonstrating a prominent insulin resistance or propensity to have hypoglycemia, or he or she is having a MASLD, then pioglitazone should be considered, maybe even first or second line. So the basic mechanism of action is it antagonizes the PPAR gamma and to some extent alpha, whereby there is gene transcription which causes increased hepatic glucose uptake, decreased glucose production, and thereby improving the tissue sensitivity to insulin. So various evidences which show that pioglitazone, it helps in CV mortality. So in this multi-database cohort study showed that pioglitazone is associated with a statistically significant 42% and 37% reduction in CV and non-CV mortality respectively. The more important study is the proactive trial, which was a prospective multicenter randomized double-blind placebo-controlled trial with 5,200 patients, 35 to 75 years, and these patients already had a pre-existing macrovascular disease risk. So these patients, we normally tend to avoid glitazones or any kind of thiazolidines in a patient who is already having a CVD. But this study had a patient who are at a risk of macrovascular disease. So primary endpoint was all-cause mortality like non-fatal MI, stroke, acute coronary syndrome, endovascular or surgical intervention, or coronary or leg arteries or amputations above the ankle. The secondary endpoint was time to the first event of death from any cause, MI, stroke, and cardiovascular death, and time to individual components of the primary endpoint. So what was seen, the primary endpoint, there was associated with a statistical trend towards improvement in these primary endpoints as compared to the placebo. Secondary endpoint, the main secondary endpoints of the key composite of all cause mortality, myocardial infarction and stroke was reported as compared to placebo. When there was the subgroup analysis, there was reduction in MACE. Then compared to MI and stroke as compared to the placebo, there was a robust significant reduction in the risk of MI and recurrent stroke. So these are the key conclusions of proactive trial, wherein there is a high risk of macrovascular complications. Pioglitazone did reduce all-cause mortality and non-fatal myocardial infarction in such patients. So other than these other components, the metabolic syndrome components are very well taken care of by pioglitazone. It redistributes the fat from the viscera to the periphery, so thereby decreasing the visceral obesity. Then reducing the BP, decreases TG, increases HDL. So all this is improved in pioglitazone. Specifically in NASH, though it is not the drug which is approved in NASH, but if we look at various studies, it improves the histological features of MASLD, reduces the steatosis, reduces the inflammation and ballooning without worsening the fibrosis. In the peripheries, it improves the insulin sensitivity in the skeletal muscles and the adipose tissue, and it resolves NASH. There are various studies, though it is not recommended but can be tried, because in India, saroglitazole is the drug which is only approved for MASLD, but on the similar lines, pioglitazone can also be tried. So to summarize, there is a high incidence of type 2 diabetes with insulin resistance. So lifestyle change and urbanization and specific drugs are the key to treating insulin resistance in our patients. It is associated with development of both macro and microvascular complications, and pioglitazone is the to the dot agent which improves the insulin sensitivity both in the peripheries as well as in the liver. So it is the optimal choice in our Indian patients. Thank you.